Hello and welcome to this very education presentation defining the 6 conditions of the depression screening in EQ. My name is Andrea Bates, District Manager with the network, and I primarily quality. So what we'll be reviewing today are the 6 conditions and the definition, other various definitions to know, and depression screening tools and their criteria. I will also have a few resources at the end of this presentation. And a copy of this presentation can be downloaded and printed out for your reference as well. Links to the resources. You may be thinking why. For those of you following any of the work that the network does, you've probably received various bits of information on how to document a depression screening in EQRS. So you're probably thinking, well, I already entered the depression screening in the patient's EMR, and that crosses over into EQRS, right? Well, it does, but there are some things and some different conditions I want to make sure every facility level social worker knows, just so they realize what they're putting into the patient's EMR and how could it affect once it's batched over. So there are 6 different conditions in EQRS. Note the bolded words in these definitions, and you may see them come up later. So the first condition is screening for clinical depression is documented as being positive and follow-up plan is documented. Followed by condition 2, which is also a positive screening, but a follow-up plan is not documented and the facility has documented the patient is not eligible. The next condition, number 3, is again another positive screening for depression. However, the facility has no follow-up plan and there's no reason given why the plan is not documented. For condition 4, that's if a patient screens negative for depression, and in that case, no follow-up plan is needed. Conditions 5 and 6 have to do with depression screenings not being documented. However, the way they differ is condition number 5, the screening is not documented, but that is because the patient is not eligible. And number 6, lastly, is a clinical depression screening is not documented and the facility has not given a reason why. So as you can see, conditions 1 through 3 are all positive depression screenings. However, they slightly differ depending on their follow-up status and how it is documented and whether or not the patient is eligible. So that's really important to know. If you screen a positive patient and document it in the patient's EMR, we want to make sure on the facility side it's documented correctly. Therefore, when it batches or crosses over into EQRS, that the correct positive screening is being indicated. So here are some definitions to know. A positive screening is just that. So it's based on the scoring and the interpretation of whatever depression tool you used. It seems to be the PHQ-9 is the most widely used depression screening, along with other tools that facilities have mentioned. And through talking with the patient, chairside or via phone, the provider should determine if the patient is deemed positive for signs of depression. And a negative screening is based on the opposite. Still the same thing, through discussion, talking with the patient, the provider determines that the patient has no signs of depression and is scored negative. So follow-up plans, like I mentioned a few slides ago, when a patient is deemed positive and a follow-up plan is documented. So it is a documented outline of care for a positive depression screen. And a follow-up plan has at least one of the following listed below. So one of these 5 bullet points are present. Additional evaluation of depression is completed. Suicide risk assessment. Referral to a practitioner who is qualified to diagnose and treat depression. So a psychologist, psychiatrist, and a licensed clinical dependent social worker. Pharmacological interventions and other interventions for follow-up for the diagnosis or treatment of depression. When you read that a patient is not eligible, that was one of the conditions that was mentioned. So not eligible for follow-up means that they're not appropriate for a patient to undergo treatment or therapy for depression because such treatments can be medically contraindicated. So also, if a patient's not eligible for a screening, here are some of the reasons that you can document a patient ineligible for screening. Patient refuses to participate. They are in an urgent or emergent situation where time is of the essence, and to delay treatment would jeopardize the patient's health status. For example, say you're going to give the patient depression screening because they are due, and as you're walking over, the patient maybe goes into a hypotensive state and their blood pressure drops and the staff need to tend to the patient immediately. Or more drastic, a patient codes and CPR and 911 needs to be called. Obviously, you wouldn't start to do a depression screening at those times. Situations where the patient's functional capacity or motivation to improve may impact the accuracy of results of the assessment tools. So certain court-appointed cases or cases of delirium, also a patient may display cognitive delay, cognitive symptoms such as dementia or Alzheimer's, maybe other severe cognitive states as well where you cannot complete a depression screening. The last 2 reasons for ineligible for screening is patient has an active diagnosis of depression or the patient has a diagnosed bipolar disorder. This means that it is somewhere in the patient's medical record that they have been diagnosed. Many times you will hear people say, well, that patient has bipolar, that patient has depression. However, is it documented somewhere in their EMR that they have these active mental health disorders? And I always like to include some of the depression screening tools that are available. Like I said, the patient health questionnaire, PHQ-9, seems to be the most used. And I've also included the PHQ-A, which is for adolescents, the CES-D10, or Center of Epidemiologic Studies, the Beck Depression Inventory, the Hamilton Depression Rating Scale, the Geriatric Depression Scale, and the Generalized Anxiety Disorder. Some of them also have the other languages that are available, so all these links are active. So when you're trying to decipher which screening tool to use or how it can be the most effective, here are a few points to consider. Making sure that the screening is available in multiple languages. On the slide before, I gave some examples of tools and included the different links as well. How are the screenings administered? Sometimes the patient takes them independently, like say that we can give it to the patient while they're on treatment, and they'll complete it. Mostly they are administered by the staff, preferably the social worker, and they actually read the assessment to the patient and the patient answers. And sometimes you can give it to the patient to complete at home. I've seen this happen if a patient is concerned about HIPAA and concerned about their personal business being talked about in the unit. And then the ability to distinguish between somatic pain and depression in patients with ESRD, since the characteristics are very similar. Here are some additional resources for you to click on and read. They are available in IPRO's Knowledge Portal, which is the Clinical Depression Screening and Follow-up Reporting in EQRS. Also, entering the Patient Clinical Depression Assessment in EQRS, as well as some additional information about reporting in EQRS. That concludes this very brief presentation. Thank you so much. And the contact information for the network and myself are available just in case you wanted to get in touch and have any questions. Thank you.